Musculoskeletal Radiology. Bone tumors. Epiphyseal tumors. Chondroblastoma. Introduction. Chondroblastoma, a rare but important tumor that you should be aware of, especially when studying bone lesions in children. Demographics. Tumor usually occurs in children and adolescents. Why? Because it develops in areas where the growth plate has not yet fused. That means it's primarily seen in younger individuals whose bones are still growing. Radiological features. One of the hallmark features of chondroblastoma is something called chicken wire calcification. Imagine tiny, thin lines of calcification that look like a delicate wire mesh. This is a classic finding that helps radiologists and doctors identify the tumor. Common sites. It has a strong preference for the epiphyseal regions of long bones. The epiphysis, as you know, is the rounded end of a bone near the joint. Common sites include the proximal humerus and the distal femur. So, if a young patient presents with pain and swelling around these areas, we might consider chondroblastoma as part of our differential diagnosis. Giant cell tumor, GCT. Demographics. Unlike chondroblastoma, which occurs in children, GCT primarily affects middle-aged adults, typically between the ages of 20 and 40 years. Location. Most common location is distal end of the radius. It can also occur in other long bones. Radiological features. On X-rays, giant cell tumors present with classic soap bubble appearance. What does that mean? Imagine a lytic lesion, which is a region where bone destruction occurs, surrounded by thin sclerotic margins. These are the edges of the lesion that appear slightly denser on the X-ray. GCT starts in the epiphysis of the bone and extends toward the metaphysis. This pattern of growth is a hallmark feature of this tumor. Clinical note. GCT is considered locally aggressive, meaning it can invade nearby tissues and cause significant damage if untreated. It rarely metastasizes. Treatment often involves surgical removal to prevent further complications. Diaphyseal tumors. Adamantinoma. Tumor has a strong predilection for the tibia. In most cases, you'll find it involving the shaft or midsection of this bone. Clinical features. Clinically, adamantinoma is a rare tumor, but one with malignant potential. An interesting feature often seen in patients with adamantinoma is bowing of the affected bone, particularly the tibia. This bowing is due to the tumor weakening the bone structure. Histopathology. Histologically, adamantinoma has features that resemble ameloblastoma, a tumor of the jaw. Epithelial cell arrangements, you'll notice similar patterns here, which is why these two are often compared. Radiological features. Adamantinoma appears as a lytic lesion, a region of bone destruction. One key characteristic is cortical involvement, where the tumor invades the outer layer of the bone. This feature helps differentiate it from some other bone lesions. Ewing sarcoma. Demographics. Tumor is seen predominantly in the first 2 decades of life, usually between the ages of 0 to 20 years, making it a key differential diagnosis in children and adolescents presenting with bone-related complaints. Clinical features. Ewing sarcoma is highly aggressive and often accompanied by signs of systemic inflammation. Patients may present with fever and laboratory findings, such as an elevated ESR, erythrocyte sedimentation rate. These systemic symptoms make it stand out from some other bone tumors. Radiological features. One hallmark feature is the onion peel periosteal reaction, where the periosteum reacts to the tumor, creating a layered or laminated appearance around the lesion. In addition, the tumor is often seen as a large permeative lesion with an aggressive periosteal reaction. In advanced cases, you may observe a sunburst appearance or Codman's triangle, both indicative of rapidly growing, aggressive bone tumors. Important notes. Categorized as one of the small, round blue cell tumors, a group of tumors that share similar microscopic characteristics. One of its most defining features is the presence of a T1122 translocation, which leads to the formation of the UWS FLI1 fusion gene. This genetic marker is crucial for diagnosis and highlights the tumor's unique biology. Osteoid osteoma. Demographics. It can occur at any age, but it's most commonly diagnosed in young adults and adolescents. Clinical features. One hallmark symptom of osteoid osteoma is nocturnal pain, meaning the pain gets worse at night. Pain is relieved by NSAIDs, such as aspirin or ibuprofen. This happens because the tumor releases prostaglandins from its central core, known as the nidus. Radiological features. Osteoid osteoma is typically found in the diaphysis, or shaft, of long bones, like the femur or tibia. On X-rays or CT scans, you'll notice a central lucency, which is the nidus of the tumor. This lucency is surrounded by a zone of reactive sclerosis, where the bone becomes denser as it reacts to the tumor. Another common finding is periosteal thickening, especially in cases where the tumor is close to the bone surface. Treatment. The treatment of choice for osteoid osteoma is CT-guided radiofrequency ablation. This minimally invasive procedure uses heat to destroy the tumor, providing excellent pain relief and allowing patients to recover quickly. Surgery is rarely needed unless the lesion is in a challenging location. That's all for the video. We'll see you next time.